This conference will now be recorded.
Good afternoon and morning, everybody. Welcome back to the ACRM Pandemic Task Force webinar series, where we are trying to find answers to everybody's questions regarding remote care delivery, remote patient monitoring, telehealth for ancillary services. Today's guest is Neela Swanson from ASHA. She is Director of Healthcare Policy for Coding and Reimbursement for ASHA. She's a resource for members regarding coding and reimbursement and works with the ASHA Healthcare Economics Committee, American Medical Association CPT Editorial Panel, and RVU Relative Value Update Committee. Individual ASHA members and other specialty societies and as an advocate for current procedural terminologies.
I think we're gonna have to. I don't have good success.
Can we get people to mute their phones, please? Thank you. She serves as an advocate for current procedural terminology, CPT, and international classification of diseases coding issues related to audiology and speech-language pathology. And is a very interesting person to talk to, knows a lot about this field. So there's a lot of changing information coming out daily. So Neela, welcome to the show. Hoping that you are gonna catch everybody up on what's going on, what do we know, what's changing, and what are we hearing? Neela, are you on?
Yes, I am. Thank you, John.
Okay, great.
That was very kind of you. Let me get my Terry, I think you're sharing with me, right? Let me get my presentation pulled up. All right. Can folks see my screen? John, can you see my screen?
I can see your screen.
Yep.
Okay,
yep.
Thank you.
Yep.
So, John, thank you for your kind words. I am ASHA's Director of Healthcare Coding Policy, essentially. So that is my disclaimer. I am ASHA's coding expert. I am by no means a telepractice expert. However, as with probably many of you right now, I am also all other duties as assigned. And I have been working very hard with the rest of ASHA's healthcare and education policy team to research and track what's been going on with telepractice for speech-language pathologists during this ever-changing and very difficult and challenging time. So please bear with me as we go through this, because a lot of things we are learning together right now. Just real quickly, my disclosures: I am an ASHA employee, and I develop multiple free and for-sale products for ASHA. So today I'm going to really focus on kind of the high level where you can get resources, including daily updates from ASHA regarding speech-language pathology telepractice services right now. Kind of high-level talk about billing and coding patterns for speech-language pathology and how payers are covering speech-language pathology telepractice services. So there's a lot of what we don't know going on right now. So I want to start with what we do know. So I'm going to start with the kind of the baseline. Here's what on a normal day SLPs may expect for telepractice coverage. So what isn't going to change, regardless of whether this is related to COVID-19 or if it's your average day, is that telepractice is absolutely an appropriate model for service delivery for speech-language pathologists. And of course, with the usual caveats, regardless of whether this is during a pandemic time or not, we really ask that the telepractice must be equivalent to the quality of services an SLP would provide in person and be consistent with ASHA's Code of Ethics, our scope of practice, state and federal regulations, and other ASHA policies. Okay. All right, sorry, I had a glitch there. And of course, most of you are probably aware.
Thank you, guys.
ASHA,
Sorry,
somebody's not on mute.
Make sure that you're on mute, please.
All right, so SLPs do participate in all modes of telepractice, whether it's synchronous, asynchronous, or a combination of different modes of therapy. I'm not going to spend a lot of time on this. Most of you probably know this. Now, here's probably where you are interested most in hearing about for speech right now. So, coding for evaluation and treatment of speech-language pathology services really use the same CPT codes, whether you're doing it in person or via telepractice. So, you would build the codes according to guidelines. You wouldn't, for example, use a full evaluation code like CPT code 9523 for a quick second via telecommunication technology. So if you're going to report CPT code 92523, it has equivalent to what you would report face-to-face or in person. So, and again, this is probably familiar to all of you. How do you distinguish then between in-person and telepractice services on a claim? The other thing I should have said from the outset, and I apologize, is what we're going to review now is outpatient billing, because that's where most of the action is, of course. We can talk a little bit about the challenges we're facing perhaps with inpatient services and how you might think about providing telepractices in that arena. What I will say is there's a lot of gray in that. There's a lot of areas that are just unprecedented and we've never really dealt with them before. So it's a little harder to talk about inpatient services. So my focus is going to be outpatient right now. All right, so back to the slide. So there are modifiers that you can use in tandem with the CPT codes that indicate different types of telepractice. We've got asynchronous with GQ, synchronous, which is GT, and those are HIPAA modifiers, but they can also be used in conjunction with CPT codes. Then we have another modifier, 95, which is for synchronous telemedicine service as well, and that's a CPT modifier, but again, used in tandem with any procedure code you would be placing on the claim. And to complicate matters even more, there is a place of service code 02 for telehealth. So the problem here is, and you're going to hear this a lot from me as we move through this, and it's something that drives members crazy when I talk to them, but there really is no consistency among payers regarding specifically how to put together a claim for telepractice services for SLP. So we not usually use the CPT code, that's normal, but many payers have you enter modifiers or the place of service code in different combinations, and it really just depends. I thought you had somebody not on mute.
Okay, push Y for yes. Right.
Can you please go on mute?
For those days when
Is there a way to mute people?
Mute your phone.
Okay. Sorry, guys. All right. So again, consistency among payers. So there is a lot of work that has to be done checking payers directly about what they want. So Medicare requires use of the place of service code 2. Some payers require a combination of the place of service code and perhaps a GT or GQ modifier. Some only want you to use 95 or GT or GQ. They typically don't combine those for when they use 95 for synchronous and GQ for asynchronous. So there are multiple ways that this can be accomplished, and it is important to track the payers are doing it, because if you don't use the right modifier, they often get kicked out. I have also seen some payers who use all of them and they don't really care which one they use, but that's not typical.
Hey, Neela, can I ask?
Yeah, go ahead.
Sorry, so I just wanted some context around, so the information that you're presenting now, this is your experience up until, say, 2 weeks ago. Like, these are what you've seen, or is this reflecting changes that are coming out within the last 2 weeks?
It's both, and we're going to get to what's changing. What I say is this reflects what we know now and what has been covered in the past before COVID-19, but it's going to follow a very similar pattern moving into the increased access to telepractice because of COVID-19. So I will get into that a little bit.
I just wanted to make sure that we understood what it seemed like what you have presented right now, and that, this is sort of how things have been, your experience up until this point, before COVID. Yes. Got it. Okay, go ahead.
Absolutely, yes. So this is kind of the baseline knowledge you need to know now and moving forward as we provide telepractice more and more, which is our hope and which we are seeing more and more of. The other thing we're getting a lot of questions on and have in the past is that if a payer doesn't recognize a place of service 2 code, what do you use for your place of service? And the recommendation really is that you use the place of service that reflects where the rendering provider or the originating site is providing the service. So not the location of the patient, but the location of the provider. And in most cases, that would be a clinic or 11 for a private practice or an office. Okay, moving on. All right, the one thing I do want to get to on a baseline for now. So, but this gives context because not everybody's moving straight to telepractice right now. So most payers, including Medicare, do not reimburse SLPs for evaluation and management codes, the virtual check-in codes, e-visit codes, remote patient monitoring, and these are some examples. You can get them all in there. For example, 99091 should probably be on that list. These are typically not covered for use by SLPs across most payers. There you'll find some exceptions, but not many. All right, and really quickly, there are several, actually most states have licensure requirements and policies regarding telepractice, and then some are specific about SLP's ability to engage in telepractice, others are not. Same with laws passed requiring Medicaid or other commercial plans to pay for telepractice. It's kind of 50 there, whether they specify whether speech language pathology is accepted provider type for telepractice. So we actually have extensive information on that on our state-by-state pages. If you click on the specific state, it will give you telepractice information and what the licensure laws and regulations are around that. And also, we are tracking temporary changes to laws and regulations during COVID-19. May have opened up the licensure to allow more providers to provide telepractice. So we are getting that information on a daily basis. So I encourage everybody to keep checking ASHA's website if you're interested in starting to practice or to implement telepractice. The other thing that we're trying to track, but it's a little harder to track right now, is any waivers regarding practicing across state lines without a corresponding license. And then, as I said before, you're going to hear this a lot from me. Even with all these laws that are in place, coverage of telepractice for SLPs really varies widely among payers, and this isn't going to change just because it's COVID-19. It's going to take a lot of tracking to see what those policies are for each payer for SLP. So under current Medicare law, SLPs are not statutorily authorized to be providers of telepractice for Medicare beneficiaries. Medicare calls it telehealth, so it's the telehealth benefit for Medicare. But there is a caveat in that because Medicare telepractice isn't covered for SLPs, it's considered an excluded benefit, which means you could potentially enter into a private pay contract with Medicare beneficiaries to furnish telepractice services for SLPs. And of course, it has to be with the patient's consent. Of course, we know this isn't an elegant solution because many Medicare beneficiaries can't afford to pay out of pocket, but it's the one workaround we have with Medicare telehealth at the moment. But of Medicare Advantage or Part B plans do have the flexibility to cover telepractice services, and that would require additional tracking.
Neela, have you heard anything? So we had someone on yesterday, Carrie Nixon, who does a lot of work with the American Telemed Association, and one of the things that they had been looking out for was anything that came out yesterday in the bill that might relax some of the telehealth televisits for ancillary support services. And the American Telemed Association, you know, they were interpreting some of the language yesterday that it would. Has ASHA seen that? Are you are you still processing that, or do you have a different opinion from the American Telemed Association? What any thoughts on that?
Absolutely. So there is in the COVID-19 package. Again, people, please go on mute. The COVID-19 package, relief package, does include giving Medicare the ability to extend providers provide telepractice during this time. It doesn't specify who, it just gives Medicare the authority to do that. So it may take some additional advocacy on our part, which we are absolutely going to do and are already doing. But it's Medicare specific as far as I'm aware right now, because the other plans have a lot of flexibility. Medicaid and commercial plans have a lot of flexibility to do that on their own. So yes, I disagree with what you've heard so far. The thing is, it's not specific, so it will take some extra advocacy.
So it kind of opens
with
the door.
CMS. Absolutely.
It opens the door, but there's still work to do. Is there, and that was one of a lot of the members that were on yesterday were asking, is there anything that they can do with you? Is there any way that they can help their voices be heard with CMS to make sure that if there are changes that come, that SLP, PTOT, and others are included in the, lifting that ban?
Absolutely. And what I would say is to monitor ASHA's website. So we're updating our COVID-19 information on an almost daily basis, depending on what's going on. So I would say monitor our COVID-19 update website, and I've got the links to those resources near the end of the slide deck. I would also say monitor. We have a Take Action site. So in addition to advocating with CMS, we are still actively advocating with Congress directly to permanently extend telepractice services to SLPs and other ancillary professions, so that, you know, this is something that goes beyond COVID-19. So there are a lot of things there are a lot of moving parts right now. When the law is signed, when it's signed into law by the president, we'll know more what kind of advocacy we need to do. So it is kind of a wait and see right now, but the wait and see we hope will happen very quickly.
Yeah. I mean, we were on the phone with one of our hospitals in Atlanta this morning, and you know, they're facing a challenge where they had a COVID-19 patient there in their ICU and on vent, but they recovered, and now they're not really sure. You know, they're faced with a whole new set of challenges of where do they send this patient, because the step down units and tertiaries aren't accepting patients that were active COVID patients. A lot of the home health agencies they're not servicing the area because they've had to furlough staff, or they were worried about staff carrying the disease from home to home. And so they're trying to provide rehab services, but there's a good chance that patient's going to have to go home until they're cleared to be seen somewhere else, and they don't really have any choice other than to provide remote services to this patient. So it just, and that's just one patient. That's not not to say, in situations like New York where you've got thousands of them.
Yeah. So. And what I will say to that, and I'm going to get to that soon, is just that because things are changing so quickly, just in general, and everybody's trying to figure it out, the payers are actually starting to really mobilize and really consider those types of situations, looking at how they can expand telepractice services. So that's something that's been encouraging. And I'll be happy to share more information about what we know on that in a couple minutes here. Folks,
Great.
if you could mute.
Yeah, if you can mute your phones, people, thank you. Sorry, go ahead, Neela.
Okay. So then for Medicaid, and you're going to hear me say this a lot, and I think I've said this already, there's a lot of grants, but there's also a lot of flexibility to cover telepractice without any additional oversight from CMS, for example. So again, what we know now is that some states cover all services provided by SLPs for Medicaid. Some cover a limited number of CPT codes. Then there are others that may allow it in a school-based setting, or may only allow it in healthcare. So again, a lot of variability. Variability is going to follow through with the COVID-19 policies as well.
Okay.
And then again, commercial plans, same thing, lots of flexibility, but lots of variability. What I'm going to move on now to, because I think that's what you all mostly want to know, is changing. So here's what we know now. And again, I should have dated my slides and I didn't think to do it. But what I say today is going to be different from what I would say tomorrow as far as what's happening. But I think it's all mostly positive and it's very encouraging. So the thing we've been getting tons of questions on right now are about the HIPAA flexibilities that were extended in relation to telepractice. So allowing people to use platforms that aren't necessarily HIPAA compliant with FaceTime or the not HIPAA compliant Zoom or any form of those telecommunication platforms. What we've had to tell members so far is it will apply in many cases, like for self-pay patients. But again, commercial insurance plans have the flexibility to decide if they want to go with that force or that flexibility or not. Medicaid is the same way. They're heavily guided by federal policy. They can establish their own guidelines as well. Medicare and TRICARE follow federal policy, so these HIPAA flexibilities will apply. Again, as we know, Medicare doesn't cover telepractice services for SLPs yet, so it's not as relevant. But what I will say, because this is fairly breaking news, is that we recently learned that TRICARE, which normally wouldn't allow SLPs to provide telepractice services, TRICARE West and East have now both agreed to extend telepractice services to SLPs. We don't have the full details yet, but that is news, and it also means these flexibilities apply. Okay, I'm having trouble advancing the slides here. Oh, here we go. Excuse me. Okay, so Medicare. So as of today, as we already discussed a little bit, Medicare has not expanded telepractice to SLPs. We're hopeful that with the relief package, we'll really gain some traction on changing that. So stay tuned for that. We've had some progress in that they are allowing SLPs to bill for e-visits, but it's not ideal. And the thing that's been really confusing to a lot of our members is that these aren't considered telepractice codes under the Medicare benefit. So these aren't telepractice services. CMS didn't extend telepractice to us via these e-visit codes. They're also very limited in use practically. They're meant, and I should put this in here, they're for established patients. So you can't see a new patient using an e-visit code. The services must be patient initiated, and they're really mostly for brief check-ins that require some clinical decision making. You only get paid for a cumulative amount of time over 7 days, and the reimbursement is fairly low. The highest reimbursement is $33 for 20 minutes or more of communication patient portal. And that's the other thing. The CMS specified that it must be done via a patient portal. And we've been recommending that SLPs contact their Medicare administrative contractor to see if there's any flexibility for something outside of a portal, like an email exchange, for example. The other important thing to keep in mind is that these do not replace CPT codes for evaluation and treatment. They are not meant for providing full telepractice services to a patient. They're also not for real-time interactions. So again, we got excited when we saw this, but as you really think about it, there are so many caveats. It's really not an ideal solution, but it may be the only one some providers have to even check in with their patients at this time. So again, I had it here that stay tuned about the release package and what we can do to extend telepractice under Medicare.
On that,
Okay.
Neela, do you have any kind of guess, or not guess, but is there anything that you're hearing either from CMS or just sort of through the grapevine on when something might be coming out around that, or what type of time frame you're personally expecting, like, to hear? Do you think it may be as early as next week that you are expecting to hear some more sort of practice specific guidance around what they're going to be allowing or considering?
I would say a week is probably extremely optimistic. I'm trying to be politically correct here. I would say that CMS has a lot to think about. I am aware of, that have been, they're going to release some further telepractice guidance that we had heard some rumors about. But as far as I'm aware, they haven't even released that guidance yet. So I think based on my discussions with CMS staff, there's so much going on. I would personally say, and this is just me, say that a week is probably optimistic.
Yeah, I'm just thinking about the study that was released this morning from WashU, looking at some predictions around when they're expecting or predicting that we might see peaks, in mid-April and really extending along into July. It just takes time to get these programs up and running. You've got to train people. So, I don't know if reimbursement is necessarily stopping people from moving forward with programs, or if there's like, well, we're going to do this and reimbursement may just catch up. But I didn't know if, those types of reports that are starting to come out from, universities and researchers that we all know, if that's, I'm sure that those are things that CMS is considering. It's just, well, anyway, I'm preaching to the choir. Go ahead.
Yeah. No, I totally get you. And I would say they are working as fast as they can for being a government agency.
Okay.
The information that they released initially, including opening up those e-visit codes, was pretty fast for CMS. So I know they're working on it.
Got it.
And of course, it also is contingent on this actually being signed into law, which we are all hopeful will happen, right? Okay. Okay, somehow, all right, my slides are going crazy. All right, so Medicaid. So there's a ton of action going on in Medicaid right now. We are actively going through state by state and looking mostly at the fee service, the main traditional state Medicaid programs, and looking at what they're doing. And we are seeing a lot of action there. So we're seeing state mandates or emergency orders that are beginning to take effect. And we're seeing some pretty big decisions around telepractice. There are some states that have added specific groups of providers, such as SLPs. Others have just opened practice up to all providers as long as they can establish that it's clinically appropriate for the patient and they have all the necessary equipment. Many are extending the same HIPAA flexibilities that the federal government did. Some are doing things a little more incrementally, much like Medicare, which is expanding the availability of e-visits or telephone check-in, or they may be doing both that and expanding telepractice to everybody. I've also been seeing a lot of waiving of originating site requirements to allow for telepractice to occur at the patient's home. So just lots of action going on there. And we are actively tracking that, and we are putting together a document that should go live today, later today, that shows our initial path at looking at what states have started doing, and then we'll keep that updated as we get new and verified information about specific to SLPs.
Great. And then on that, the site requirements, are there any requirements around providing those if the therapist is at home? Because a lot of them are, you know, they're not, especially for ambulatory, they're at home. Is there anything, does that pose a challenge, or do they need?
Well, and that's part of the kind of the gray area. What I've been telling members is, and this is just me, we haven't been seeing, not based on our research so far, we haven't been seeing specific things at say we're waiving the distant site requirements, you know. So it's been focused more on the originating site because they're focusing on the fact that patients have to be at home. I haven't personally seen much about the distant site or where the clinician is. Now, what I've been telling our members is if this is where you're providing your services for the foreseeable future and you'll be submitting claims from this location, then you could consider it your office. I've heard some people say, shouldn't I use the place of service code for home? And the answer is no. That reflects where that is more about where the patient's location is. So if you go to a patient's home and provide services, then you would do that. But because you're providing the services as distant site from your location, you would want to say office or something along those lines.
Got it. Okay.
And again, tons of action on the commercial plan side as well. You know, when people started contacting us right when, you know, we really started realizing that COVID-19 was going to significantly impact how we provide services, people called us and said, what are they doing? What are they doing? And of course, we had to tell them they're trying to figure out COVID-19 right now. Presentation is actually happening at the perfect time where, you know, plans have been able to kind of stop reeling from that and start thinking of more long term. So we're starting to hear from plans daily now. We sent out hundreds of letters, ASHA did, to state Medicaid agencies, to the major commercial plans, asking them to expand services, and we're starting to hear back. So for example, last night at 11:59 p.m., United Healthcare has expanded telepractice to SLP and PT and OT across all lines of business for COVID-19 purposes. So that means their Medicare plans, Medicaid HMO plans, their regular commercial plans are all extending telepractice services to SLPs. That's a lot of beneficiary lives. And we've also from Cigna, who's doing who will be expanding. I don't know if it's going to be across all business lines. We believe Aetna will be expanding shortly. So we're really starting to get information in and they're providing us more specific information as well as like what codes to use, what modifiers to use. So we are also collecting that information in a tracking table, and we'll have that up later today. And we'll be adding that information as we get it. As you can imagine, it's harder for us to track those than it is for state Medicaid agencies. So we're going to just be adding what we know as plans contact us or as members contact us and can verify that they're getting coverage by a specific plan. So again, you can see what I talked about earlier about what we do know is these plans are expanding so quickly, a lot of the times they haven't had time to really flesh out their policies. So it's good to know how to just basically code and use modifiers for SLP services just in general, because it will apply as plans start to expand. So as I've said before, I think you really just need to stay tuned. ASHA, and I'm sure all your other professional organizations are posting things daily as we know them. And I already mentioned our tracking resources there. And the other thing that would be helpful, especially for the SLPs on the line, if you want to contact us because you know a you found out from all your advocacy and your calling and your checking that X plan now covers telepractice for SLP services, shoot an email. And if you have verifying documentation or a link, that would be great too, and we can add that to our resources. That's the one thing that we're really talking to our members about is the local advocacy and you calling a plan and urging them to cover services often works more quickly than anything else. And we're all just trying to help each other right now.
Great. That's a lot of very good information, and we'll have those links on. We'll repost those too under the ACRM COVID page, and so that people have a place for those to go. And then we'll have all the information from Neela's presentation there as well. So if any of you have questions for Neela on what she presented today or other issues that you're facing regarding SLP, please post those into the chat. One of the questions that we have so far is for the states that do not have any laws on telehealth in regards to speech, what do you suggest we do to provide telehealth services?
So if they don't have any laws at all, it's really up to the payer. And again, even when there are laws, unless they explicitly say, you know, commercial insurance or Medicaid must cover SLP services, even where there are broader laws, it's up to the payers how they want to implement it. So, and as much as I hate to say it, it becomes a one-on-one tracking of what the payers are allowing.
Got it. Okay. The next one is from Alan. How is ASHA participating with other rehab professions for advocacy on Medicare?
Oh, we work very closely with our colleagues at APTA and AOTA and other professions, but mostly APTA and AOTA to advocate with Medicare. There's a bill, it's the Connect bill. I only know our nickname for it is the Connect bill that we've been working collaboratively on. And I'm sure you, my colleagues from APTA and AOTA will be talking more about that when they do their presentations as well. But we work all the time with our therapy or our sister or brother therapy organizations.
Great. And his follow to that is, and what can how can we help as practitioners other than reaching out on the individual claims to privates that, you know, as individual providers and practitioners are working within organizations, what how can they add their voice?
Well, I would absolutely, I know we all have different take action platforms. If you go in, I should have included that link. It's takeaction.asha.org for ASHA. It's really sign up for email alerts through our Take Action site, because that's where a lot of, where we need a lot of help is when we need to do a call to action to write to members of Congress and to talk about the importance of our services. For ASHA, I would also just monitor our COVID-19 page. And also, if you're interested in hearing all news related to ASHA, I would also sign up for ASHA headlines. And if you go to our website and just search in our inbox, or I'm sorry, our search box for ASHA headlines, you'll find out how to sign up. Right now, it's so fluid. It's, you know, going to be mostly just follow what we're doing, and if we have a call to action, please just help.
Great. Okay. So on the announcement from, I'm just trying to get through these. Kimberly, if United and others begin extending telehealth service reimbursement, is that applying to inpatient as well as outpatient? Were there any qualifications on United's announcement?
Oh, sorry. Go ahead.
No, go.
It's mostly outpatient, because that's where, you know, payers have really thought about telepractice. Inpatient is such a different animal because, you know, the stays are paid more on a per diem or per stay bundle. So you aren't dropping actual billing codes. And so it's, you know, and I know inpatient settings are thinking about this, even just for patients who are on quarantine and, you know, the SLP shouldn't go in and come in direct contact with them. And we're actively talking with some of the other specialty organizations like the American Hospital Association, the NASL, to kind of start really figuring out, so what are the policies? How do they apply to inpatient telepractice services? Some of the things we talk about is when it's in a per se bundle, it may be appropriate to provide telepractice if you're in the hospital with the patient, for example, but you're in a different room. It may just be part of the stay, right? So it may just be a mechanism to put the situation at hand, but it's also fluid. I would also get your compliance officers involved, and your administrators and those who really know the policies of the hospital and the payers they work with. It's just very complicated.
Got it. Okay, that's good to know there's work being done there. What are the documentation requirements for reimbursement? Will ASHA be providing recommendations and templates from Rebecca?
So the documentation requirements, honestly, are pretty much the same as what you would do for an in-person visit. The only thing that may be different is that you actually document that services were provided via telepractice. ASHA has, and these are all, when you go, I didn't provide very many links, because when you actually go to the links that I have, we've got a ton, and I'm not even kidding when I say it, a ton of resources on telepractice, including best practice recommendations. We don't have templates per se, but we do talk about documentation requirements.
Okay, great. And then, so, sorry, it just jumped down. Are there any certain programs, platforms that are recommended for telehealth, considering HIPAA, et cetera, from Alyssa?
We don't recommend platforms. I would go look at the American Telemedicine Association or talk with your colleagues. Zoom has a HIPAA compliant version if you're looking for something that's a little bit more affordable and easy to get, but we really provide recommendations. But with the flexibilities, things like FaceTime and whatnot are also acceptable, but that's if you know that you have the flexibility to do that.
Okay, and then from Allison, our governor said teletherapy is temporarily okay across all disciplines and payers must reimburse for it. Does this supersede what's happening at a nationwide level?
Absolutely. If the governor said it and it's in an emergency order, then it supersedes what's going on at the federal level, unless they choose to adopt whatever's happening.
Great, okay.
And we're seeing a lot of that, the emergency orders.
Okay, great. Will ASHA provide any information regarding billing and documentation for inpatient SLP services via telepractice from Margo? So another sort of looking at inpatient, and it sounds like that's sort of just really being developed.
And that's something we're only just starting to talk about. I don't know that we would, kind of on principle, ASHA tends to stay away from templates per se, just because it's hard to cover all payer requirements. But we are starting to talk about the inpatient issue. It's just, what I would say about any documentation is document the way you always have for face-to-face. And that is safest that you'll need to document the unique circumstances. So if you are providing it via telepractice, you'd have to describe why and why it was medically necessary and why it was appropriate for that patient.
Okay.
And that doesn't change.
Got it. From Allison, does ASHA have definitions on e-visits versus virtual check-ins versus remote patient monitoring, et cetera, for their and how that applies to their members?
We have definitions for the e-visits right now because most payers aren't covering remote, and the check-ins we haven't established kind of corresponding information on that. But once we get through kind of this initial review we've been doing, and we are seeing our programs adopt some of the other codes, we'll be adding information to our website to help our members. Absolutely. We're doing the absolute best we can to analyze what we know and get it up there as fast as we can.
Okay. From Ginny, we have outpatient SLP, however, we bill off of a UB. Is telehealth billable on a UB?
Yes, it should be. And I'm just familiar with the UB, but yeah, I've seen a lot of payers documentation on deal with the UB as well.
Okay. From Shannon, are you aware if coverage has been granted for telepractice evaluations for AAC devices?
That will depend on the payer. I'm thinking for United Healthcare. See, and that's the thing. All of this is breaking. There are some payers that allow it for AAC devices, and others that don't. It just really depends. Some only limit it to like the 92507, which is the speech and language treatment, and it evals. It really just depends.
Okay. And then from Maria, we are in outpatient rehab but bill under hospital tax ID. Do the rules you discussed today apply to us if we're attached to the hospital tax ID?
But if you're still an outpatient clinic, it should still apply, absolutely.
Okay. And then any payment for remote patient monitoring yet?
Again, that will depend. I've seen very little of the remote patient monitoring for SLP. In fact, even in some of the expanded telepractice services policies I've seen from Medicaid, is they've still only allowed RPM for mostly physician service. So it's gonna vary.
Okay. Okay, well, those are all the questions that we have. You know, I think it was very informative. Neela, thank you very much for taking time out. I know there's a million things going on at ASHA. Oh, we've got one more.
Two more.
Two more. Is UHC covering services provided if the therapist is completing visits remotely?
Yes. So remotely as in telepractice, I'm assuming. So yeah, so United Healthcare literally just expanded telepractice services effective today to SLP, PT, and OT.
Okay, and then if an inpatient is unable to provide consent for telepractice due to cognitive status, reduced level of alertness, but consent is given by their POA responsible party, is that acceptable?
That should be acceptable. You'd want to document that. And I know that a lot of payers are saying verbal agreement is okay. I am err on the side of caution person. So if you have some way to do a DocuSign or something like that, that might also help you document it as well.
Got it. Okay. And then on the previous question, she regarding covering services provided the therapist is completing visits remotely, she qualified that and said remotely as in doing visits from home if quarantined.
From your home. So we're not seeing a lot of specific information about that. And what my recommendation has been is if that's where you're going to be providing most of your services during this time, just document that. So if you're working for a hospital or something like that, you might want to work with your compliance officer as well. And this is just me. I'm not a lawyer, I'm not a law expert, but this is just me and kind of just observing what's been going on with COVID-19 is I would find it hard to imagine a regulator not being okay with that right now. And that's just me saying,
Yeah.
You know, given the extraordinary circumstances, I don't think there's going to be a lot of scrutiny on that.
Right.
But don't quote me on it. I'm not a lawyer.
Well, and that kind of leads to the next question. You know, if you don't have access to DocuSign, what do you think of a screenshot of a PDF you sent to the patient to sign, i.e. email, and they can show it to you and you can sign the screenshot? I think kind of in light of what you were just saying, you know, I think taking the most advantage of what you have available to you.
Yeah.
You know, you're making
do the best you can.
Right, it's a reasonable effort. You've made being able to prove reasonableness that you did make an effort to make that to get that documented.
Yep, and it is a lot of it is everybody's just doing the best we can at the moment, and I think if you make every reasonable effort to do the best you can, that's all you can do. That's
great. Neela, thank you very much for your time today. You know, stay safe. Tell everyone back at ASHA that help and if they're that thank you from ACRM and our members for bringing your expertise, and we'll be posting all of this information and links back to ASHA's site of their daily updated pages and everything else, as well as the session notes and on the ACRM pandemic website. Stay tuned. Tuesday, we're going to have Alice Bell from the APTA and have our sort of PT-centric presentation. But of course, we welcome everybody. So stay safe, have a good weekend, read a book, play some board games, and we'll talk with you next week.
And thank you, John. I will just feel free to contact ASHA at reimbursement@asha.org. I would give you my email address, but I can't guarantee you I'll get to that any faster than we can get to reimbursement@asha.org. But we are always looking for information. We always want to help our members the best we can. So thank you, everybody.
That's great. Thank you for that.
All right, take care.
Have a good weekend.